The following podcast is part of a certified educational activity titled Optimizing Care for High-Risk Myeloid Cancers, Interprofessional Team Insights from a Center of Excellence. Access the entire activity and complete the post-test at peerview.com/BFT860. Downloadable slides and practice aids are also available.
Hello, my name is Dr. Navadavar from the MD Anderson Cancer Center. Welcome to this panel discussion on exploring a team-based approach to managing high-risk myeloid cancers. I'm pleased to welcome my pathology colleague from MD Anderson, Dr. Sanam Logavi, as well as our physician assistant colleague, Megan Weiss. Sanam, Megan, a few words from you, please.
Thank you, Naval. It's wonderful to be here. I'm really looking forward to the discussion.
Thank you. My name's Megan. I'm so happy to be here. It's going to be a great discussion. Really looking forward to it.
All right. Yep. Thank you. I'm looking forward to it as well. So during this program, we're going to be using a macro mini approach to describing some of the overall approaches to high-risk disease in the AML-MDS field. And then focus on a case example of a patient with TP53 mutated AML. So with that, let's begin. So this slide kind of shows the traditional prognostic factors that we've used for acute myeloid leukemia for the last 3 to 4 decades. And as you can see, it's a combination of cytogenetics, age, white count, mutations, the more common ones that we have been using for the last 10, 12 years, FLT3 and NPM1. Now we have started incorporating additional mutations and factors that you see on the right-hand side. That includes WT1, TP53, MLL, RUNX1, and others. And I think the prognosis is becoming more and more detailed as well as more accurate with the incorporation of these markers. So in MDS, the traditional staging system has been what we call the IPSS, International Prognostic Scoring System, and this was recently updated and called the IPSS-R, or Revised International Prognostic Scoring System. And this basically integrates 5 or 6 important factors that we know impact prognosis in MDS. So chromosomes, bone marrow blast, hemoglobin, platelets, ANC, and in some cases transfusion requirements. So one of the things you will see is missing is molecular information. This has not yet made it into the traditional MDS IPSS-R classification, but it will in the near future, and updates to the IPSS-R, including and integrating molecular, are ongoing. So now moving to what I think is probably the most impactful from both prognostic and therapeutic selection is the presence or absence of not just mutations, but also mutational combinations. So we know that it's not just one mutation, but usually multiple mutations that can impact outcome. In AML, the most common mutations, as you can see, are FLT3, FLT3, very important targetable mutation, prognostic and therapeutic value. Then NPM1, DNMT3A, which are more prognostic, although there are new drugs that could target NPM1 that are being developed, such as menin inhibitors. And then you have others, IDH1, IDH2. Now, one mutation that is not the most common, but is probably the most impactful from a prognostic point of view is TP53. And this is seen anywhere from 8% to 10% in younger AML, up to 20% in patients with 65 years of age or above with AML, and has the worst prognosis in general. There are other factors that may help refine the prognostic impact, and this was an analysis that was published from our group very recently, just a few months ago, which showed that it's not just a binary mutation, meaning if you have TP53, it's bad. If you don't, it's good. In fact, the TP53 outcome depends heavily on the allelic burden of the mutation, whether it's one or multiple TP53 mutation, as well as the associated cytogenetics. And what we usually see is that patients who have multiple TP53 mutations, higher allelic burden, 40% was the cutoff we used, as well as associated abnormal cytogenetics, have an inferior outcome, whereas the small group of patients who actually have low allelic burden, single TP53 mutation, especially if they don't have associated adverse cytogenetics, can in fact do reasonably well with cytarabine-based regimens. So I think this is one effort, and many others are being looked at by many groups to refine the impact of TP53. Now moving to MDS, very similar approach where there are different mutations, but the actual mutations themselves are different. And this is now actually showing us that MDS AML are not the same disease. A lot of times people say they're a continuum, same disease. Not necessarily. In fact, the mutations you see in MDS, newly diagnosed, are quite different. They're heavily epigenetic and RNA splicing mutations. You do not see the signaling mutations like FLT3, RAS, or IDH1, IDH2 in the same frequency. And so this is probably indicating that the biology and potentially the treatment of MDS eventually will be different. This is a very nice article similar to the AML one that I showed you from our group. This is from the Moffitt group, showing that again TP53 mutation, especially the higher TP53, more than 20% or more than 50%, was associated with quite a worse outcome. So again, like AML, TP53, especially with high allelic burden, is associated with a bad outcome. So here I'm going to turn it over to Dr. Logavi to discuss some of the more intricate aspects of TP53 and this recent manuscript.
Thank you. Yeah, sure. So this is really a landmark study that was recently published in 2020 by Elsa Bernard and Elie Papamanuel at Memorial Sloan Kettering. I think this paper is very important in solidifying our understanding of the role of TP53 in myeloid neoplasms. So as you know, TP53 is a tumor suppressor gene. And really, the detrimental impact in the setting of myeloid malignancies and other cancers is when you have biallelic loss of this tumor suppressor gene. So it's very important to look at this from an integrated approach and look at mutations as well as chromosomal loss or deletion, which we do by either conventional karyotype or by FISH, if you suspect that there's a TP53 abnormality on routine cytogenetics. And then also one other thing that routinely is not being done in the clinical setting, at least, is copy neutral loss of heterozygosity. And this is something that I think we need to be focusing on in the future in our clinical settings, because once you have biallelic loss of TP53 through any mechanism, be it mutation, deletion, or copy neutral loss of heterozygosity, then you have a much, much worse prognosis compared to having just a single hit, either via mutation or via deletion. Now, we know that in the majority of the cases, when you have a complex karyotype, you have usually biallelic loss. You have a mutation and you have a complex karyotype so that you lose both copies. But it's very important to be aware of this caveat when you work up the patients.
Yeah, thank you very much, Dr. Logavi. I think, a lot of these articles we're showing are getting to that message that it's not just TP53, yes or no. Something with FLT3, for example, over the last decade, we have learned that this is very much impacted by the allelic burden, the associated cytogenetics, and the copy losses. So I think it's going to become very important in the future to get all that information when we determine the patient is TP53 mutated. And I think, as we will discuss later, that may actually even play into the therapeutic decision making, whether it's the frontline therapy or the transplant potential as well. So now kind of shifting more from the general didactic overview to focus on a patient and how all of this information can hopefully be integrated and used. So this is a 73-year-old patient, Helen, who is presenting with fatigue and other symptoms like weight loss, shortness of breath, common symptoms we see in AML or MDS presentation. Past medical history, has some hyperlipidemia, hypertension, coronary artery disease, stents placed 2 years ago. So nothing really acutely going on at this time in this patient. And I guess the question here is, what would be the next steps for working up this patient who has these symptoms and is a older individual? So here I'm going to turn it over to Megan, who works very frequently with me in clinic. And how would we approach this patient, Megan?
Absolutely, thank you. Yeah, for this patient, very common presentation, older individual who comes in through the emergency room, Fatigue, weight loss, shortness of breath, we see that very commonly. So the first thing obviously we want to check is the CBC. Some of these patients may have had this checked outside, some of them may not. This may be a brand new diagnosis. So we obviously want to check for the CBC, check common labs, coagulopathies, all of those as well. Another thing we're going to do with a patient like this is to go ahead and do a bone marrow. So we're lucky enough in our center to be able to handle about 40 to 60 bone marrows a day. We're able to do those in the emergency room or in an outpatient setting as well. We're able to do that usually within about an hour. That gives us a quick turnaround to get this patient hopefully admitted and maybe stabilized as well. Usually transfuse the patients too. A lot of these patients will show up with a very low white count as well, so we'll start the antimicrobial prophylaxis with an antibiotic, antifungal, antiviral, and usually get the patient situated in the hospital where we can monitor them much closer.
Yeah, absolutely. I think, getting to a diagnosis here will be the key. And of course, we're concerned about some form of infection or hematological process. So working the patient up will be with the bone marrow, blood work would be the next steps. So in this case, as we're getting the workup done, the patient gets admitted, as you said, through the ER for these symptoms, and we get the standard blood work, CBC, differential, chemistries, liver enzymes, etc., bone marrow same day. And then I guess at this time, let's say we've got some of the CBC results, and these are on the next slide. So let's say these are the CBC results. You see the white count low, hemoglobin low, platelets low, absolute neutrophil count is low, otherwise normal organ function, ECOG is 1, and we have some of the prelim bone marrow results here. So what would be the things, Megan, we would start talking to this patient about at this time regarding their stay and what to expect from therapy?
Absolutely. So for these patients, typically, especially since they're 28%, we know that we'd like to keep the patient close to get them started on treatment. So to do that, we usually ask for them to stay about 30 days while they're around the center. That does usually mean that the patient needs to find housing. They need to get situated in the outpatient center, and to do that, we do have a great team of social workers and case managers who can help us get them set up for housing. A lot of times too, these drugs are expensive, so we'll have to talk to them about funding. We'll also have to talk to them about clinical trials. Some of these patients don't have any exposure to treatments. They aren't sure really what they're walking into. So a lot of times these first discussions are explaining the disease process to them, explaining what we're looking for in terms of prognosis and how long to expect to stay here, possible complications associated with treatment. Really everything that they may run into, especially over these first 30 days where they're getting started on treatment and their counts are going to change significantly, how they feel is going to change significantly, and really talking about what they want for quality of life and if they'd be able to go back home for treatment, stay here. It's really usually a long discussion, but able to really understand what the patient's looking for as well as what we're looking for from treatment.
Yeah, I think that's what, a lot of times is not discussed or covered in a lot of the lectures and discussions we do, is that this is really different from most solid cancers where there's an acute change, not just in the medical condition, but also in the social condition of the patient and many times economical condition, because, with an acute leukemia, often the patients have to stop working immediately. They're admitted, whether it's at their local center or the large academic referral center. They're usually in the hospital for the first 30-35 days, and often it's many months before they will be in a condition where they're able to return back to full-time work. So I think this is where, as Megan was saying, we work very closely with our social workers, case managers, financial assistants. We're very fortunate to have many different charitable organizations providing funding and support, and this is something that is happening in the background from the day one when the patients come, which is often not discussed. We focus on the medical, but this part is extremely critical for us to deliver very rapidly. That's the key here. We have to do this quickly. We cannot take 3-4 weeks to start treatment and then proceed. So with this, I'm going to now turn it to Dr. Logavi here to discuss the approach. And when she gets a bone marrow sample at MD Anderson from a suspected AML, what are the steps she takes and information she will be trying to get.
Yeah, absolutely. Thank you. As you said, this is our job is to try and come up with the most accurate diagnosis as fast as possible. So this is essentially what goes on behind the curtains between when the patient gets the bone marrow done and when we are able to inform the treating team with the information they need to proceed with treatment. So we get the bone marrow in the laboratory probably about 1 or 2 hours after the bone marrow is done. We make aspirate smears on the same day, and we're able to look at these smears and essentially say that the bone marrow blast count is increased or it's not. Is there an infiltrative process or not? So we're able to come up with a preliminary diagnosis, and we usually run a preliminary flow cytometry panel on our bone marrow aspirates that gives us an idea of whether it's a myeloid process or a lymphoid process. So this is what we release on the first day, and we're in constant communication with the treating team, telling them, giving them live updates as the information becomes available to us. We are still doing cytochemical stains at MD Anderson, and I know that not every center is doing these stains, but we still find it very informative. It's rapid, it's inexpensive. So we like doing these. We like doing an MPO stain to say that something is myeloid. We do esterase stains to identify monocytes and monocytic leukemias. And then obviously the next step is to process the bone marrow. We get the core biopsy out the next day, so we're able to issue a final report usually within the next day. And then the molecular studies and the cytogenetic studies, including the karyotype and FISH, take a little bit more time. So as I said, the aspirate and the flow are usually next day or same day turnaround time. The cytogenetics lab usually takes about 3 to 8 days to issue a final karyotype, and the variability in that is essentially dependent on the rate of growth of the cells. So if you have an acute leukemia that's rapidly proliferating, you're going to get a karyotype sooner, whereas if you have an MDS that's a less proliferative process, it's going to take longer to issue a karyotype. We do same-day FISH for detection of PML-RARA, core binding factor acute leukemias, and BCR-ABL1, which we're very proud of. We're usually able to issue those results within 4 hours. And then we do additional FISH as necessary for, let's say, KMT2A or MLL rearrangement if there's a suspected monoblastic leukemia. And then the molecular studies include FLT3, which we usually turn around within 2 or 3 days. And then our NGS panels. So we have an 81 gene custom myeloid panel that's used for all of our suspected myeloid neoplasms, including AML or MDS. The whole panel is usually resulted within 3 to 5 days. However, we do have a custom pipeline that's been developed by Dr. Patel in our laboratory. So we're able to report on 10 specific genes within essentially 1 or 2 days because we're able to do this using unidirectional sequencing. And these genes are the ones that are highlighted in the top box. The reason these were chosen is that IDH1 and IDH2 were important for selecting therapy. Some of the other mutations, such as calreticulin, MIPL, or JAK2, are important for making a diagnosis on some of the myeloproliferative neoplasms that are not as straightforward. And then obviously NPM1 had prognostic and therapeutic implications. And TP53 is also in the pipeline, so that's going to be added to this rapid panel as well.
So as you can see, it's intricate communication between our hematopathology, our physician assistant, and nursing and social worker teams to really get these acute myeloid leukemia and myelodysplastic syndromes a complete, comprehensive, accurate diagnosis and select therapy. Dr. Logavi will know I have her contact on speed dial, as with all her pathology colleagues, and we at MD Anderson are always pushing to get the timelines shorter, and as you can see, we're already at a very, very good level, but the quicker we can be and the more efficient, the better we get it. So we're very appreciative of all the efforts from our molecular, hempath, cytogenetics colleagues to get us that information so we can start treatment. And I think this field will only continue to grow, so the information will get broader and broader, and we are trying to keep abreast of all those progress. So over here, I'm going to turn it back over to Dr. Logavi. Now we're going to kind of zoom in more on a very specific high-risk group of AML, the TP53, and how they identify this group in the HemePath lab. So please go ahead.
Yeah, absolutely. Thanks. So this is an example of an acute or a pure erythroid leukemia, which is a form of AML. It's highly enriched for TP53 mutations and complex karyotype. On the left-hand side, you can see images of the bone marrow aspirate showing immature erythroid blasts. As I said, we do cytochemical stains. So here on the bottom right, we have an MPO that shows that these cells are negative for MPO. And we have an internal control, a neutrophil that's positive on the upper left-hand side of the slide. And then you have a PAS stain that shows these abnormal globules that are staining positive that confirms that these cells are of erythroid origin. And then we also do flow cytometry, as I said, the same day on the bone marrow aspirate. And we can see that there's a population of cells that are CD117 positive. They are CD45 negative, as shown in the gate, the red gate on the plot. And then these cells are CD19 negative and CD13 negative, CD34 negative, and CD123 negative, which is all in line with an acute erythroid leukemia. And then once we do the bone marrow core biopsy and we've processed the core biopsy, you can see that on this slide, the cells are immature. They have very prominent nucleoli. There's a mitotic figure right in the center, so this is a very proliferative leukemia. And these cells are uniformly positive for CD71, which is an erythroid marker. Again, they are negative for myeloperoxidase by immunohistochemistry. And then we have the advantage of having P53 immunohistochemistry, and we look for overexpression of the protein. In the majority of the cases where you have missense mutations, you're going to see overexpression of the protein. But one caveat to be aware of here is that in the cases with nonsense mutations or truncating mutations, you may see a null pattern of staining, which is complete absence of staining, and that is abnormal too. So when we see P53 overexpression, such as seen in this case, usually it's pretty concordant with the mutation results, and we can predict that there is a mutation. So as you can see, we get the karyotype back and the NGS studies back. So the karyotype is shown on the left-hand side, and the red arrow is highlighting a 17p deletion, and this is the TP53 locus. And on the right-hand side, these are the NGS results visualized by integrated genomic viewer. You have a DNMT3A mutation with a variant allelic frequency of about 10% and a TP53 mutation with a variant allelic frequency of about 10%. Now, in this case, it's very important to note that, as we discussed in the Bernard paper, this patient has biallelic loss or a multi-hit TP53 alteration, because you have one allele lost via chromosomal deletion and then the other one is mutated. So this renders this patient very high risk.
Thank you very much, Dr. Logavi. And I think, again, highlighting that it's very critical to get the full support and have a advanced hematopathology molecular cytogenetics group all working in tandem to get this information. One of the things I will say at MD Anderson, as Dr. Logavi mentioned, we are using IHC for kind of an early look to understand if a patient could be high risk for TP53 mutation. And this will take us to why that is so important for us to know early. And this is the therapeutic landscape. So this is the approach, it says at MD Anderson, and that's true, but this is also kind of the general approach, I would say, being used in most academic centers in the United States. So for a newly diagnosed AML who is considered fit for or able to tolerate intensive chemotherapy, we are looking for 5 factors in the beginning. One is APL, acute promyelocytic leukemia. We didn't talk about that, but we always check a FISH for translocation 1517 to make sure we're not missing an APL, which would have a completely different therapy and a very good outcome. But once we know that, usually within the first 6 to 8 hours of the patient coming to the emergency room, we're looking for core binding factor. Again, we can catch these with FISH probes within 24 hours or with cytogenetics within 48 hours. And for the other patients, we are looking for mutation, especially FLT3, to add FLT3 inhibitor, and as well as adverse cytogenetics or MDS-related cytogenetics, for which we may consider other therapies such as CPX351, which has shown in a phase 3 study improved response and survival in people who have therapy-related secondary AML and AML with MDS-related cytogenetics. So again, using cytogenetics, FISH, and molecular all together to select the upfront therapy for the patient. Now, TP53 is unique in which whether the patient is fit for intensive or not fit, the historical publications have shown very similar outcomes. Intensive chemo and HMA both give about 30 to 50% CR/CRi, median survival 7 to 8 months. So for us, the best chance for these patients is to go on some of the trials that have started showing activity in TP53-AML. These include drugs like CD47 antibody, Migrolomab, or APR, which is a TP53 folding directed therapy. For older patients with acute myeloid leukemia, similar approach. HMA-VEN is now the established backbone based on the VIALE-A study that showed in a large randomized multinational study that azacitidine venetoclax improved response and survival over azacitidine alone across all older AML. The two groups that the benefit was not as profound were the TP53 and FLT3, and so we are still trying to find ways to improve outcome, whether it's azacitidine venetoclax with TP53 directed therapies such as CD47 antibodies or azacitidine with CD47 antibody. And so again, knowing that TP53 very early within the first 1 or 2 days, even with an immunohistochemistry till I wait for molecular, helps me to say I'm going to wait for this patient to select a CD47 or APR sort of therapy and not go quickly with azacitidine venetoclax for that patient. So here, looking at myelodysplastic syndrome, the approach is overall we want to know if the patient is high blast, high risk MDS. We're using the IPSS-R most commonly on the ongoing trials, or their lower risk, which is defined by a low IPSS-R score. For lower risk, usually it's more supportive care, growth factors, as well as Revlimid in patients who have deletion 5q. Sometimes we use low dose HMAs. For the higher risk, the treatment approach is very similar to acute myeloid leukemia, where we're using HMA or HMA venetoclax, in fact, more and more, or we're using intensive chemo in patients who have more than 10% blast and are younger, because these patients can have good remission and transplant. Now, we're also using novel therapies, and there are many new combinations in MDS that are starting to show very encouraging promise, not yet FDA approved, but in advanced trials, such as azacitidine with CD47 antibodies, azacitidine with venetoclax, and azacitidine with other drugs like pevonedostat or sabatolimab. And especially again for that TP53 group, we carved that out separately and are going for the CD47 SERP alpha sort of drugs in combination with azacitidine because they are showing the most encouraging activity for that high risk subset. So now moving back to the case. So we discussed our patient, 73-year-old, confirmed case of AML. Now we know she has TP53 mutation and her bone marrow also shows adverse cytogenetics. So without doubt, this is a adverse impact TP53. You have both the mutation and adverse cytogenetic as well as significant dysplastic changes. So I'm going to turn it back here again to Megan, because she will be seeing these patients usually before me in the clinic as we get their information, cytogenetics, pathology, molecular. And Megan, what are the things you would discuss, treatment options, inpatient, outpatient, other things with the patient?
Yeah, absolutely. So with a patient like this, one of the big things that we work to help them understand is the high risk nature of their disease. A lot of these patients aren't familiar with this type of disease since it is rare, so they don't understand really how much this is going to change or impact their life or their lifestyle. So a lot of our communication, as we discussed before, is really getting them settled here. And once we get them settled, going through what their bone marrow shows in a way that they can understand it, and also kind of what we're looking for in the future. A lot of patients, when they first come to us, they assume they can do chemo and then they'll go home and that's all that they'll need, but they don't necessarily always understand the longevity of the treatment or the transplant or any additional aspects. So a lot of times that's what this first meeting is to go over, is really what they're at, what situation they're in, and really what the future will look like. along with that, we talked about it can be very expensive with these medications. So we have the benefit of associations like HealthWell and Leukemia Lymphoma Society, where we can apply or help the patients apply for funding to help get these medications covered. Not only do they have to get chemo treatments sometimes covered if they're oral, they also have to get their antimicrobials, and a lot of times antifungals can be more expensive than the medications that they're used to, like a lisinopril or a hypertension medication. So we spend a lot of time working with them, trying to make sure their medications are at an amount that they can afford, and also have them continue with treatment. With this too, we started to talk about really what are they looking for. Are they looking to stay here with us? Most of them are from out of town, so not only would they have to be here for the first 30 days for a clinical trial, but sometimes they just want to completely move and stay here. They're more comfortable with a closer monitoring, or they live in an area where they don't have access to clinics like they would if they just stayed here near us. So those are things that we're considering, because if we're talking about oral medications, they do have more flexibility in where they're at and what their lifestyle will look like. Or for some of the patients who need IV chemotherapies, they may not have access at home to centers that can provide these IV medications. So a lot of times this is really how we help determine treatment. And two, the nice thing about clinical trials is you have the added benefit of research nurses and people who can help monitor them. But it does require closer monitoring and to be at the center more. So it's one of those where we really need to discuss what is the patient looking for, as long as they also understand the high-risk nature of their disease.
Yeah, thanks a lot. And I think you brought up a very important and nice point that I want to highlight a little more, is the importance of clinical trials. So, I think we see this very frequently in our clinic. We have a very large AML clinic at MD Anderson, is that there's a lot of confusion about what is a clinical trial, and people confuse clinical investigation with experimentation. They sound the same, but they're very different. So almost all the trials that we do usually give you standard of care plus. So if aza-ven is the standard, we have a lot of trials now of aza-ven plus FLT3 inhibitor, plus IDH inhibitor if you have the mutation, plus CD47 or Migrolomab, plus Venetoclax. So in general, we would not be doing a trial if we did not believe it could push the field forward. There would be no benefit to doing a trial that is already kind of established standard. And I think, as we have Venetoclax, it came through trials. As we have new drugs like Migrolomab, they came through trials. So I think it is very important to consider trials, whether you're a physician or patient, whether it's in the frontline setting or relapse. Now, of course, sometimes logistically, financially, time-wise, it's not possible and one has to start therapy. But I think it's always good to have a consultation, whether it's email, phone call, or if the patient can travel officially. Now, Venetoclax is very important. I think we should briefly discuss that. And Megan and our PharmDs help admit the patient and start Venetoclax-based therapies, which are used very frequently in older AML. So Megan, maybe you want to talk a little about the precautions and the guidance we give for Venetoclax treatment.
Right, so we do use quite a bit of Venetoclax. It is a wonderful drug, but a lot of times we do have to explain to the patients the side effects, because what they think is they're taking just another medication, like we were talking about their hypertension medication or diabetic medication, whereas with these patients, the big thing we have to concentrate is keeping them hydrated and the risk of tumor lysis. And so a lot of times we'll admit the patient and do a ramp up. So in patients who are on Venetoclax in a high-risk situation like this, they're also going to be on an antifungal. So it's something that we have to discuss with them, is the importance of how their antifungal interacts with their Venetoclax. So most of our patients are going to be on either posaconazole or voriconazole. So we'll usually put the patient on somewhere between 70 to 100 milligrams of Venetoclax. And in some of these patients, they may come in with a higher white count. In this situation, the patient's white count was 1.2, so we're good to start. But usually we'd like for the white count to be less than 10. That kind of mitigates that risk of the tumor lysis. And so what we'll do is also keep the patient hydrated, start them on IV fluids, usually allopurinol, and help to slowly ramp up the Venetoclax so that the patient can tolerate it, mitigate some of that risk of the AKI that we typically see if we start the patient with a higher white count and with less hydration.
Yeah, and I think that's very important that, as you mentioned right in the beginning, the Venetoclax being oral, one may have this false sense of it being a very mild medication. I mean, it's highly effective and probably one of the biggest breakthroughs in AML therapy. But as you said, it does require good monitoring, tumor lysis prophylaxis, ramp up prophylactic antibiotic, antifungal, and then if done well, could be a great option. So now all these options are on the NCCN guideline for this patient using HMA alone, HMA with Venetoclax, clinical trial, of course, and even CPX351 because this patient is 60 to 75, which was the phase 3 target population and does have MDS-related cytogenetic changes. So you could use any of these. So the question is, how do we select? And so I'm going to try to show some of the data that helps me make this selection, and then we can decide what would be the best treatment maybe. So Venetoclax, no doubt, as I mentioned, is a major breakthrough in older frontline AML. But when you look at this bar graph, what you can see is that among the different mutational group patients treated, the lowest response rate is with TP53. And this is something that we have now seen in across 3 different studies, the phase 1b single agent, the phase 3, and our own MD Anderson decitabine 10-day Venetoclax, where the CR/CRi rates are about 50% compared to 75-80% with almost all other mutational groups. And 50% is not bad because we know with AZA alone it would be around 30%, and with chemo also it would be around 30-40%. But the median survival both in the Viale study as well as the MD Anderson decitabine 10-day Venetoclax in TP53 was only 5 to 6 months. So clearly Venetoclax is not a major breakthrough for TP53. We were hoping it would be, but the data is suggesting it has marginal, if any, benefit to HMA. For all other mutational groups, in fact, it does seem to have a very clear, distinct benefit. So this was our effort then at MD Anderson to say, okay, well, AZA alone and DAC5 alone with Ven may not be enough, but there was data in New England from the WashU group 6 years ago showing that decitabine 10-day had some form of preferential specific impact in TP53. So we said, well, what if we do the decitabine 10-day and add Venetoclax? Maybe it will be a breakthrough for TP53. And unfortunately, we have not seen that. The CR/CRi rate is about 55%, maybe a little bit higher than AZA-Ven, which is 50%. But unfortunately, most of these are not MRD negative. And really what's concerning is that the early mortality in TP53 mutated with DAC-Ven versus the TP53 wild type in that same study who got DAC-Ven is very high, 26% 60-day mortality. And this is something we have seen in clinic, is that the TP53 AML, not only are they resistant, not only do they not achieve MRD negativity, but they have very profound severe cytopenia and risk for infections. So it's not even an efficacy issue many times. They will unfortunately die from infection a lot of times very early on. And so maybe a therapy that is less myelosuppressive, less infection, and can ease them into remission could be important approach. Looking at MRD negativity, again, here you see when you look at all the patients who achieve MRD negativity, again, this was across the 100 plus patients on our frontline DAC10 Ven, the TP53, even though they may achieve this 60% or so remission rates, very, very few of them, only 26% of the responders, so 10-15% of all treated patients are MRD negative. So what could we do? So one of the things that has emerged as being potentially a next major improvement for TP53 ML is a very novel approach. It's using an immunotherapy. As you know, immunotherapies are being used in many, many different types of cancers. But here we're not using the immunotherapy everybody's used to thinking about, which is T-cell immunotherapy, PD-1, PD-L1, CTLA-4, CAR-T, BiTEs to activate T-cell against tumor. Here we're actually using a different cell component, a macrophage, and blocking the inhibition to macrophages, which occurs through CD47 SERP alpha interaction. And by blocking that negative interaction on macrophages, we unleash the macrophages to do what we call the eat me signal and promote phagocytosis. And there are many CD47 SERP alpha drugs in clinic now for AML MDS, at least 3 with some more coming, but the one that has been most advanced that has clinical data that has been published is the drug Migrolomab. This is a CD47 antibody, and as you can see here, in AML patients showing encouraging response rates about 65% or so, a little bit lower than AZA-Ven across the board, but actually pretty encouraging when we note that AZA alone gives you about 20-25%. But really the thing that has got us most interested is the activity in TP53 mutated AML, where with emerging data, we are seeing almost 70% CR/CRi rates, and these seem to occur early. And really importantly, we don't see a high early mortality. The early mortality is 5 to 6%. So it may be that this is an easier therapy, less severe myelosuppression than Venetoclax, which can be managed in general, but maybe in TP53 has a preferential impact. And again, here, when we look at the cytogenetic and MRD negativity remissions, they seem to be higher than what we have seen with HMA-Ven, and we will have more updated data hopefully later this year. And in the end, survival is the key question, and this data suggests that the median survival of 13 months could be achieved in TP53 mutated AML. Now again, this is single arm, and the confirmatory phase 3 has started looking at Aza-Ven versus Aza-Magro in TP53 AML. But indeed, if we could get above 11-12 month median survival in AML TP53, this will be a major step forward, because as you saw with Aza alone, DAC alone, DAC10, Aza-Ven, it's been 5 to 7 months. And again, to me, we've probably used Migrolomab extensively, and maybe the most in the country. And what really started getting us excited initially, even before we saw this efficacy data, was the safety. Very, very safe drug. We don't see prolonged neutropenia, thrombocytopenia, myelosuppression. The one thing we do see is an early anemia, usually within 10 to 14 days. And this is actually on target because RBCs express high levels of CD47 and can be mitigated by intrapatient dose escalation. We have not seen any severe or critical outcomes, but that is because we're monitoring and transfusing. So the thing to think about. And as you can see, the 60-day mortality here was 0, which is really quite impressive. And this may again be a reason of the difference in the TP53 AML, where with HMA-Ven we had 20-25% early mortality. Also, high activity in TP53 MDS, and in fact, there's a second phase 3 looking at MDS. In MDS, in fact, the phase 3 is looking at all comers with higher risk IPSS-R using Aza-Magro versus Aza. TP53 will probably be enriched because of the extrapolation from the AML data, but there is data suggesting it could work across the board. So now here, the patient, after all this discussion and summarizing some of the data we have seen, we would probably encourage an HMA CD47 or an HMA CD47 Venetoclax if we had such combination, and the patient agreed to proceed with that approach. So at this point, Megan, I'm going to turn it back to you to discuss how we would get the research nurses involved and what role they play in our practice.
Absolutely. So the research nurses are a really helpful part of our team. They're able to basically screen our patients. So they'll look at the history of the patient, they'll look at any prior treatments, and kind of look at their overall picture and see clinically would they be able to handle this type of medication. They then will go through, and with the patient, they actually come in, they will consent the patient, they'll go through all of the details that the patient is asking for, and then they also help kind of maintain with their lab work as well. So they'll check labs frequently with us, and they'll help manage any type of side effects, or they'll help talk about what other patients are possibly seeing with the clinical trials. They're very helpful in terms of helping to manage the overall picture of the clinical trial, because a lot of times what happens as either the mid-level or the physician, we get very focused on what's happening with the patient in that moment. So they're there to help remind us, this CBC needs to be checked this frequently, and the patient needs to be monitored for this, and these are the side effects that we're seeing. Just because, as in these clinics, we see patients having all different types of treatments. So they're there and they focus on that one specific clinical trial. They'll also help with monitoring the patient more long-term. So they're able to help see how the patient does on other treatments, even after their clinical trial is ended, and they help kind of capture data on how the patients have responded, because a lot of times in clinic we get so focused on the bone marrow looks like this right now, this is what we expect will move on, and how the patient responds, whereas they're looking to see there too, is the patient doing well, and what did they start at, what was their baseline bone marrow, and this is where they're at now. So they help us track all of that information. It's a lot of extra monitoring that sometimes we're not able to do on all of our other patients. These research nurses will also come in, they'll do consent forms, they'll do extra surveys with the patients, they'll, help assess pain levels or swelling or any type of, side effects that we may be seeing. So they help there collect additional data for us and make sure all the patients are really being cared for in a very well-rounded manner.
Yeah, and absolutely. I mean, in MD Anderson, where, just in leukemia, we have more than 150 clinical trials, it's impossible for any one PI or PA to really know exactly the nitty-gritty and the details. And so I think they're really great support and help to us in keeping things going appropriately in the clinical trials. So now for this patient, let's say we started Marrow, we admitted the patients, or we do it outpatient. It depends on how far the patient is from. And I think I'm going to turn it back to Megan here to discuss a little bit about the anemia issue and management with Migrolomab, because that really is probably the only side effect we have seen frequently with this drug. But Megan, go ahead.
Yeah, I agree. Really, this drug is very, very well tolerated. The anemia is something that we do see early on. So with these patients, and really almost all of our AML patients in general, we're going to monitor labs at least 2 to 3 times per week. Our center is set up so that the APPs are able to just do what we call fast track and review. So we're able to pull labs 3 times a week, meet with the patient for 15 to 20 minutes, make sure everything's going okay, and transfuse as needed. So in a patient such as this, especially during that first 2 weeks, 3 weeks where the patient's on treatment, if they're in the outpatient setting, we'll do labs 3 times a week. I'll transfuse them. We usually would like the threshold for their hemoglobin to be above 8.5 if possible within that first 2 weeks, because we do know there will be a severe drop, and we're able to then catch it with that really close monitoring. Sometimes too, patients such as this, where they sometimes are treated heavily before, they can come in and say, hey, I'm not feeling well today, I need some extra labs, and we can always add them in for lab work. So that is a really nice part about them being on a clinical trial and being close, is that we do have the ability to check labs quickly and get them transfused as need be.
Yeah, and I think again with Migrolomab, this is very important, just like with Venetoclax, the TLS and the ramp up and neutropenia management is important, that these are not AZA alone. They are AZA plus, both in efficacy, but also in some of the myelosuppression effects. So one cannot give this treatment, whether it's AZA-Ven or AZA-Magro, and say, let's see you in 4 weeks. I think the patient could end up with major severe complications. So you need labs. Either you do it inpatient, depending on the logistical support, or at least 2 to 3 times a week. And as Megan said, we try to get their hemoglobin above 8.5, even closer to 9 before starting, because we know there could be a drop anywhere between 0.5 to 2 points drop I have seen in the first 10 to 12 days. So moving along, the patient started therapy, we managed anemia, everything went well. After day 10, 12, usually the anemia is no issue anymore, and overall she achieved a partial remission, blast went down, counts have improved. And what we have seen with a number of these drugs, and especially with Migrolomab and other immune therapies, is that it takes 4 to 6 cycles, ideally, usually, to get to the full deep remission. So even if we see some stabilization, initial partial reduction, we keep going till we get to a full remission. Now, when we say remission, though, what are we talking about? Is it just morphology? Is it flow, molecular, cytogenetics? And here I'll turn it back to Dr. Logavi to talk about the follow-up bone marrow workups we do.
Sure, thank you. So as you know, one of the most important prognostic indicators in any patient with AML is measurable residual disease detection. And we try and use every tool at our disposal to detect measurable residual disease. Initially, back in the day, we were limited to morphologic reviews. So, the definition of CR is based on blast count, really, and, the 5% cutoff. But we know that in reality, that's a very, very crude and simplistic method of looking at this. So we basically look for anything that the patient had pre-treatment, whether it be a cytogenetic abnormality that we could detect by FISH, or nowadays with routine use of NGS, we look for mutations, and we also use flow cytometry to look for AML clones or aberrant myeloid blasts. Again, we use these tests selectively based on what the patient had initially and before treatment. the turnaround time is pretty much the same day, be it for measurable residual disease detection or at initial diagnosis. So in the case of Helen, she had a TP53 mutation, as you can see on this slide. And when you look at the left side, this is her baseline NGS, and the little C's indicate where the sequence read was mutated inside that dashed line. So if you look at those, she had about 70% variant allelic frequency of her TP53 mutation at baseline. Whereas if you look at the panel on the right-hand side, which shows her post-treatment sample, she has very few mutant reads, and the rest of the blue reads are basically just wild-type sequence in the background. So now she has that variant allelic frequency of the TP53 mutation at about 2%, and she has achieved MRD negative status by flow. Again, it's very important to realize that these methods are not perfect. They're usually complementary. Flow is heavily dependent on sample adequacy. NGS is a little bit more, I would say, objective and less open to interpretive expertise. But again, none of these are perfect, and we usually do them in combination because it gives us the best accuracy, and we're able to provide the treating clinicians and the treating team with the best and most informative results.
Thank you very much for that discussion, Dr. Logavi. And so now turning over to the take-homes and conclusions here, I think what we have shown and what we strongly believe is absolutely it is important to get molecular and cytogenetic information at baseline. As you see, this can impact not only prognosis, not only transplant decision-making, but also the initial therapy. And it is no longer one-size-fits-all 3+7 approach. We now have at least 5 or 6 different categories of AML that could benefit from the addition of particular drugs or using different agents. Also, as we don't often discuss, but it is very important and critical to note that this is a very true collaborative effort. Of course, the clinicians, we're seeing the patient making decisions, but we depend extensively on getting the right information quickly from our hematopathologist, molecular cytogenetic colleagues. And then, of course, we also depend very heavily on physician assistant nurses, PharmDs, and research nurses in centers that do extensive research to get all the logistics and get the actual plan moving forward. TP53, I think, is still a major area of unmet need. We're starting to see some glimmers of hope and progress with some of these new agents, new immune drugs, and hopefully one or more of these will reach approval and improve outcomes with TP53 and lead to further combinations. And we are very excited about the safety as well as efficacy we have seen in high-risk MDS AML in general and in TP53 with some of the CD47 macrophage activating drugs, which seem to be a potential new addition, hopefully in the future for myeloid malignancies. So with that, I would like to conclude our panel discussion on high-risk myeloid cancers. Any last comments, Dr. Logavi?
No, thank you so much. This has been great, and I think it's really important to emphasize the integrated approach that we take and the team approach that we take, and it really takes a village to deliver good care.
Yeah, absolutely. And Megan, any comments?
Yes, I completely agree. It's really teamwork makes the dream work. So it's really been super helpful to have such a wonderful team, and it's been an absolute wonderful discussion as well.
Absolutely, I agree. It's wonderful to have you and a great team at Anderson and everywhere else where we're all working hard to fight against AML and MDS. So I hope you all found this program interesting and useful for your practice. Thank you all for joining us.
Thank you for listening. Download materials and complete the post-test for instant credit at peerview.com/BFT860. This activity is supported by an educational grant from Gilead Sciences. This activity is accredited by Medical Learning Institute, Incorporated. This activity is developed with our educational partner, PVI, Peer Review Institute for Medical Education.